Thank you, Rajesh. We begin our next course, which is microbial keratitis, evidence-based medicine. And I have with me galaxy of speakers. Workup of case of microbial keratitis and bacterial keratitis would be dealt by me. Fungal keratitis would be talked upon by Dr. Samar Basak, Director Disha Hospitals, Barakpur, Kolkata, West Bengal. Sir, may I please request you to be on the dais? Acanthamoeba keratitis would be talked about by Professor Rajesh Sinha, who's Senior Consultant at RP Center for Ophthalmic Sciences, AIIMS, New Delhi. Then we would come to the surgical management, glue and dalk and microbial keratitis by Dr. Rajesh Fogla, Apollo Hospitals, Hyderabad, and therapeutic keratoplasty and microbial keratitis by Professor J.S. Tityal, Chief of RP Center, AIIMS, New Delhi. Rajesh Fogla is there. So I would request Rajesh to please come on the dais. Dr. Rajesh Fogla.
Dr.
Rajesh Fogla. Two of them are there. So I would be talking to you about workup of case of microbial keratitis and bacterial keratitis, which would be dealt with similarly. There are no financial interests or disclosures, and this is how a case of bacterial keratitis would look to you. This is a classical case of Pseudomonas keratitis with yellowish discharge, yellowish greenish discharge, and a cornea which is perforated. Symptoms we all are aware of: redness, sensitivity to light which is increased, visual acuity which is decreased, pain, discharge, associated conjunctivitis. And whenever associated conjunctivitis is present, it could be due to gonococci, pneumococci, or Haemophilus. So this is what should be kept in mind. Now, the risk factors could be ocular, such as corneal abrasion, eyelid disease, contact lens use, prior ocular surgery or ocular surface disease, compromised corneas, or injudicious use of topical antibiotics, steroids, or traditional eye medicine. The risk factors could be systemic, which would be immunosuppressive drugs, burns, chronic alcoholism, severe malnutrition, AIDS, malignancy, and rheumatoid arthritis, and even extremes of age, such as infancy and old age. These are the classical pictures to see how microbial keratitis or bacterial keratitis would look like. Traditional eye medicine, honey, bacterial keratitis, then post-LASIK keratitis because of a buttonhole flap, and these are two cases where there was injudicious use of corticosteroids, following which perforation and thinning has occurred. So in a slit lamp evaluation, this is the classical picture. You have to look at the area and density of infiltration, size and depth of ulceration, size of epithelial defect, degree of stromal edema, scleral involvement if any, and AC reaction. And not only do you have to look at the size of the epithelial defect, because the size of the epithelial defect is always going to be different from the size of the stromal involvement or the size of the infiltrate. So both should be monitored at each visit. And of course, you would also see whether the hypopion is mobile or it is not mobile, such as in this case it is mobile. That means it possibly rules out your fungal keratitis. Grading of corneal ulcer is important, whether it is bacterial or fungal, because the treatment modalities for each of the grades is different. So the way to learn is less than 2, 2 to 5, and more than 5, mild, moderate, and severe. Likewise for depth, less than 20%, 20 to 50%, more than 50%. And infiltrate extent similarly, and scleral involvement is present only in the severe cases. Now, this is just to show that the severe forms of microbial keratitis have poorer outcomes, are likely to be larger and likely to involve the posterior cornea. So that is why it is important to know the size of the ulcer. Now, classical features are present with organisms. So if you have a staph microbial keratitis, you would have compromised corneas. The local borders are going to be distinct, and the non-edematous surrounding cornea is there, which is relatively clear. On the other hand, if you have a pneumococcal keratitis, it is a rapidly progressive serpiginous ulcer, hypopion with deep stromal abscess, and your surrounding cornea is also edematous. What has happened? Pseudomonas species, on the other hand, has ground glass stromal appearance with fulminant green discharge, infiltration which happens in 24 hours, desmetocele and perforation which can happen in 2 to 5 days. Mycobacteria, on the other hand, will have a classical cracked windshield-like appearance such as this. The surrounding cornea is quite clear and there's hardly any AC reaction. And this occurs after trauma and is generally indolent. So you can see that this is a classical cracked windshield-like appearance. Atypical mycobacteria keratitis can also occur, and the picture is classically like this. Again, it tends to have a cracked windshield-like appearance and has multifocal infiltrates, as is shown here. Then Moraxella is classically inferior, is oval, hardly any SC reaction, and seen in diabetics, alcoholics, and malnourished, and is generally indolent in nature. And Nocardia has a cracked windshield appearance and also a wreath-like pattern which can be seen here, which is again indolent with elevated hyphae edges and satellite lesions. Now, there are limits to clinical evaluation. In this study, in fact, 2 studies have clearly shown that you can distinguish between bacteria, fungal, and amoeba in almost 3/4% of the cases, depending upon your clinical examination. But for the 1/4 of the cases, you still require microbiology, which remains the mainstay for any case of microbial keratitis. So the scrapes are taken by using proparacaine and from the leading edge of the ulcer and the center of the ulcer, and one can use a modified Kimura spatula, which most of us actually do not use. The most important stain, like I have always emphasized and everybody does, is KOH, because that will immediately tell you whether you have to start your antifungal treatment or not. And grams has to be done in all the cases, and acid fast is for MAN. MAN means Mycobacteria, actinomyces, and Nocardia. One does culture on blood agar, chocolate agar, and Sebrot's dextrose agar, and supplemental media may be required, LJ media for Mycobacteria and Nocardia, and for Acanthamoeba, non-nutrient E. coli. Now, everything that is related to the microbial keratitis goes for culture, whether it is a suture or it is contact lens solution, contact lens case, and the positivity rate for bacterial cultures varies anything between 40 to 73%. Now, you may have a lot of cases which are referred to you. So, important thing is that you should see whether you have a microbiology report or not. If the microbiology report is present and the ulcer is still not responding, then you have to look at 3 things: compliance, resistance, and whether it is mixed or polymicrobial and you're missing some other organism. However, if the microbiology report is not there and there is no microbiological diagnosis, then one can stop antibiotics for 12 to 24 hours, re-scrape and send in special stains and culture, and also on routine stains. And if it's a twice negative smear, then one does corneal biopsy. Now, for samples such as post-LK keratitis, you may have to remove a suture because the infiltrate is present in the interface. Or for cases like infectious crystalline keratopathy after LASIK, you may have to elevate this flap and scrape the area which is there on the bed as well as on the surface. And of course, you may need to do a suture biopsy in cases where the epithelium is not involved, but it is only a posterior corneal abscess, or in cases of DSEC, where only the graft is involved, the intravitreal scissors may be required to obtain the sample from the DSEC lenticule. And like I said, corneal biopsy may be required if you've not been able to obtain microbiological diagnosis on smears. There are various treatment strategies. So for mild ulcers less than 3 millimeters in size, not involving the visual axis, one can start monotherapy with Oflox, Ciproflox, Gateflox, Moxiflox, and nowadays we've started a randomized control study, both in collaboration with LV Prasad Eye Institute at Hyderabad, where we are comparing Levoflox with the conventional combination therapy. Moderate ulcers, if they are more than 3 millimeters in size and involve the visual axis, one uses combination therapy with fortified cefazolin or tobramycin, which are in higher concentrations to cover for both the gram-positive and the gram-negative bacilli. And I think in the initial part, initial 48 hours, it is important to emphasize that your treatment will go round the clock. Round the clock means even during the waking hours, at least for the initial 48 hours. And there are 4th generation fluoroquinolones which are available, and we still depend on them, although there is resistance which has been shown, and in mild to moderate bacterial keratitis, several of the randomized studies have compared fluoroquinolones with combination therapy. If the ulcer is mild, then you can get away with the fluoroquinolones, but if the ulcer is severe or is moderate, then you need to give combination therapy. I think another important thing is the resistance, which can occur even with the fluoroquinolones, which is becoming increasingly a problem. And these are the two studies of moxiflox vis-a-vis the combination therapy, and gataflox vis-a-vis the combination therapy from our center, which we published with equivalent results. This is how you prepare fortified cefazolin and fortified tobramycin for all those who don't have a pharmacy and have to do it themselves. And this is how vancomycin, which is the last drug which we generally keep, is prepared. Additionally, one can even give amikacin and trimethoprim. Now, this is a meta-analysis of various studies, 1,823 subjects, which looked at comparing the fluoroquinolones with the combination therapy, and again the results were similar. The adjunctive therapy will continue in the form of cycloplegics, anti-glaucoma medications, and I would talk about topical steroids. Systemic antibiotics are required for perforations, impending perforations, post-perforating injuries, scleral involvement, and for Neisseria and Haemophilus. Now, the SCUT trial did teach us that topical steroids can be started, but one has to be careful, I think, in three conditions or three places where the steroids should not be started, and that is nocardia keratitis, atypical mycobacteria keratitis, and fungal keratitis. You may start them with a loading dose of antibiotics have been given for 48 hours, and the culture and sensitivity report is in hand, because to every microbial keratitis, infection is important, but so is also inflammation. And I think although we've all worked on antimicrobials, there are very limited studies on anti-inflammatories for microbial keratitis, and this is where we need to work at. Of course, the clinical response, favorable signs would be decreasing infiltration in terms of area, density, epithelial healing, and decreased AC reaction. And whenever the ulcer is not healing, look for other organisms and other factors. So, modify antibiotics only if there is no clinical improvement, and taper when the clinical signs of improvement are there. And these are the specific antibiotics for specific organisms. For MRSA, vancomycin; for severe Pseudomonas keratitis, ceftazidime; for Mycobacterium fortuitum, amikacin; and for nocardia keratitis, amikacin or trimethoprim can be given. These are the AAO recommendations of 2018, and much of this I have already crystallized and talked to you about. And there is, of course, a problem of resistance, and you see the way exponentially the articles on antibiotic resistance are increasing systemically, and there is also the same resistance which has also been reported for the ocular data as well. And this keeps increasing. There are newer combinations and formulations which have been tried anecdotally: topical piperacillin, linezolid, colistin, imipenem, and when nothing works, then these are the drugs that we resort to. So for multi-drug resistant bacterial keratitis, linezolid, 2 mg per ml, colistin, and imipenem are the three drugs which can be used. This is topical colistin, 0.1%. Again, this is the way we prepare it for all those who don't have a pharmacy to help them to prepare it. Again, these have shown promising results, but there are no long-term studies or trials to talk about it. So how to prevent resistance? You use a very low dose or too short duration of antimicrobial usage would increase antimicrobial resistance. So don't taper it, just stop it when you have to, when you think that the response is there. Use the right antibiotic, and use antibiotics only when they are of benefit. Do not taper antibiotics, stop at the therapeutic dose. Again, there is no proven role of vitamin C and doxycycline or any of the anti-inflammatories, and this is something I think which we need to look at. We can, if we have time, discuss about the collagen cross-linking in microbial keratitis, but I think we need to rewind, reevaluate, and redefine our approach as to how we are going to be treating bacterial keratitis. in a more effective way, because resistance is something that we will have to stay with. So these are the sequel if it doesn't respond, and this should be the healing of the corneal ulcer over a period of time that we all are aiming at. And we are going to be coming out with the second edition of this book, and thank you very much for your kind attention.
Thank you, Dr. NAMRATA, for a very nice and comprehensive talk on bacterial keratitis. Yes, sir, please.
May I invite Professor J.S. Titial, sir, on the dais, and Dr. Sonal Tuli, who's our international guest faculty from Florida. Please, can you come up to the dais? Join us. Sorry. Yes, we can take up the questions now.
Ma'am, sometimes in our clinical practice, we come across cases of these microbacterial ulcers, where for first 2 days we find that either they are very slowly responding or they are at least not deteriorating. Day 3, suddenly you find that as if the picture has turned into a Pseudomonas infection. So what is this kind of change of pattern of these ulcers during their course of presentation? Any comment from you?
So I think if it is responding within 48 hours and then there is a change in the way it is behaving and it suddenly deteriorated, then one has to look and think about superadded infection, because that infection which is there has an epithelial defect and is already infected, and there is every possibility that there is a superadded infection, which has caused this. It could be a mixed infection, or it could be a polymicrobial infection. So I think that is what one has to look at. And like you rightly said, Pseudomonas keratitis, in most cases, to begin with only is quite devastating, is quite severe. But I don't know, but there are several other organisms also which would, behave similarly. Sometimes even fungal keratitis, especially because of fusarium, may have a very severe course, and it starts to deteriorate very fast. So I think you have to be aware about those organisms which behave like this, and also be careful that there may be a superadded infection by some other organism apart from the one which is already there.
And at what stage would you recommend TK for such cases?
Therapeutic keratoplasty, I would recommend. I think there's a whole talk by Professor Titial on this, but it should be done. The idea of doing a therapeutic keratoplasty is that when there is an impending perforation or with a maximal medical therapy, your ulcer is not responding. And I would never let it go till the limbus, because if an infection goes to the limbus, I know that from relatively good prognosis or optimum prognosis, the case has fallen into a bad prognosis case. So I would never let microbial keratitis or exudate go right up to the limbus. Would do a therapeutic keratoplasty before that.
Any role of giving anti-glaucoma drugs simultaneously with?
I think that depends on a case-to-case basis, and that can be given.
Thank you.
Just one comment. One of the reasons for contamination of the drug, a lot of reports has been come, especially when you are treating with for a fungal ulcer, then Pseudomonas reports come that even the natamycin contains Pseudomonas organism. So be careful about the drop.
Drop itself.
Patient is using, that is the most common source of Pseudomonas super added infection in our country. So